definition. So to bring some homogenization in communication, there are some definition as far as acute variceal hemorrhage is concerned. So what is the first definition? This is something called time zero. What is time zero? It refers to the time of admission to a medical facility. Time zero refers to the time of admission to the medical facility. What is the acute variceal bleeding? The acute variceal bleeding refers to the episode of acute bleeding which comprise from time interval from hospital admission, that is your time 0 to day 5, that is up to 120 hours. What is clinically significant bleeding? Clinically significant bleeding means probably the quantity of bleeding is more. What could be, how you can say, either patient can have hypotension. So your systolic blood pressure is less than 100 mm of mercury, or if it is not a frank hypotension, probably you can have a postural syncope. So posture associated change in blood pressure of more than 20 millimeters of mercury, or you can have a compensated shock in the form of tachycardia, heart rate of more than 100 per minute. What else you can have? Or you can, there could be a requirement of multiple units of RBC transfusion, more than 2 units of PRBC transfusion. So if there is any of these requirements, then probably it indicates that something called clinically significant bleeding. So what is there any other definition? So this is called treatment. It is a AI generated image. This is something called treatment failure. So what is treatment failure? So within the time window of early bleeding, so within the time window of acute variceal bleeding, that is within 120 hours, if patient exhibited any of the following clinical features: fresh hematemesis, more than 100 ml of blood in the nasogastric tube, okay, and development of hypovolemic shock, more than 3 gram drop in hemoglobin. If all these things occur after an initial control of hemostasis, then it is something called treatment failure. So what is early rebleeding and what is late rebleeding? If rebleeding occurs after 120 hours to 6 weeks, it is called early rebleeding. And what is late rebleeding? Late rebleeding is something which happens after 6 weeks. Okay, so these are some of the definitions involved. So time 0 is time of admission to the medical facility. Acute variceal bleeding episode is nothing but from the hospital admission time to 120 hours, which is day 5. Clinically significant bleeding is nothing but the vitals monitoring and symptomatology. Either you can have a systolic blood pressure of less than 100 or tachycardia of more than hundreds of heart rate, or postural syncope, that is difference in systolic blood pressure of more than 20, or requirement of more than 2 units of blood transfusion. Treatment failure is nothing but after initial hemostasis within that 120 hours of time frame, when there is a fresh hematemesis, more than 100 ml of Ng, fresh Ng aspirate of blood, presence of hypovolemic shock, more than 3 units, more than 3 gram drop in hemoglobin, then that is something called treatment failure. What is early rebleeding? What is late rebleeding? Early rebleeding is somewhere between 120 hours to 6 weeks. Late rebleeding is more than 6 weeks. Okay. So we will continue the scenario. So you have been called into ER to resuscitate this particular patient. So you have obtained some wide bore IV cannula. So you have taken blood grouping typing cross matching. You have sent some CBC, some blood biochemistry. You have obtained a point of care ABG for this particular patient. You have started IV fluid resuscitation, and you have sent a thromboelastography for this particular patient. Now you are wondering how much I have to resuscitate this particular patient, because in the approach to the UGA bleed, you do remember that there are 2 predominant causes of upper GI bleed. One is the acid peptic disease, that is a peptic ulcer related bleed. The other one is the acute variceal bleed. We have discussed that both the situation we tend not to over resuscitate the patient, because in one, that the acid peptic disease, the source of bleed is arterial bleed. In any arterial bleed, before the attainment of hemostasis, we won't over-resuscitate because we tend to dislodge the clot, we tend to hemodilute, we tend to dilute the clotting factors, we tend to create hypothermia, thereby we tend to prevent the hemostasis from happening. That is one. Whereas in acute variceal hemorrhage, what we tend to do, here the pathophysiology is whatever the measures we have to take to reduce the portal pressure, we have to take all those measures very diligently. So in both the cases, we have to keep our resuscitation to that bare minimum extent so that the peripheral perfusion, it is a very fine balance where your peripheral perfusion is preserved as well as to avoid your over resuscitation as well. So the learning objective here is how much to resuscitate, how much to transfuse, and what targets to look upon. We will go to the next MCQ. So regarding the medical management of the acute variceal bleeding, INR should be corrected before the performance of endoscopy. Intravenous proton pump inhibitor should be administered as a standard of care for all the patients. Antibiotics should be administered only when spontaneous bacterial peritonitis is suspected in patients with variceal bleed. Terlipressin should be given only after the confirmation of endoscopic findings.